Hey guys, Anthony Avila, Doctor of Physical Therapy, owner of Avila Physical Therapy, your host of the Coastal Bend Spotlight Series. Today I'm joined by Dr. Jason Thompson, a fellowship-trained orthopedic surgeon specializing in hip and knee reconstruction and a former professional soccer player who won the 2004 MLS Cup with DC United. From pro athlete to elite surgeon, his story is all about discipline, persistence, and excellence. Let's dive in with Dr. Jason Thompson.
Hey there, man. Thank you. Nice introduction.
All right, so let's get it. Wow, that's quite a foundation. We'd absolutely love to hear more about your background story. So, soccer life, orthopedic surgeon, how did the two connect? And if you're willing to share any deeper soccer stories, I know Corpus Christi and South Texans in general are huge fanatics when it comes to soccer.
Yeah, I'm originally from Dallas, and so a big soccer bed in itself. It's all I knew growing up was soccer. Came from a pretty humble upbringing, and so just learned to cut my teeth working hard and just put my sights on a goal and worked hard to get towards them. So I initially had started soccer, went to college to play ball and was able to leave school a little early to turn pro. Unfortunately, injuries, like it is for a lot of people, were my demise. And after a 4-year career, was at a crossroads trying to decide what I wanted to do. And I think that I had always thought I wanted to be a doctor and decided that it was going to go for it. It was a bit tougher as a second career, but was able to overcome a bunch of different things and made it to orthopedics. I think it seems cliche, but a lot of orthopedic surgeons are former athletes, and it seems to fit. But coming from my dad was a plumber and a carpenter, so I was always using my hands growing up. So I was able to marry my athletic endeavors with my background and settled in quite nicely with orthopedics. As far as arthroplasty, I really like the instant gratification, I guess, in some ways instant gratification with replacing a joint that's been worn out, so to speak. And so that's what drove me towards arthroplasty. As far as sports, I spent most of my life in sports, and I thought it was a good transition to watch them rather than be involved in them. So a lot of people ask me why I didn't sports medicine, but that's kind of a quick how I got there. That's kind of a easy version of it.
So what position did you grow up playing in soccer? Did you move around, or where did you excel most in soccer? At what position?
I was a forward and always a forward. You score goals and they find a place for you. And I think not only that got me to where I got, and then probably in the end got me where I was no longer playing also. So you score goals and they love you. You stop, and for different reasons, whether it's injuries or other things, you stop scoring goals and it's harder to stay on the field. But yeah, I played forward, more of a target forward. Growing up in Dallas, certainly a lot of South Texas and Mexican flair as far as the style of soccer, but more direct, also being American, but yeah, very much, I guess, what we called in soccer toque. So you kind of small touches and combined with a bigger, stronger physical body build, it allowed me to excel.
I'm so happy to hear that part of your story, because you have such a great foundation, and I'm sure that relates to what you do on a day-to-day basis today. And so, are there any parallels that you see from the hard work you put in back in the day to kind of where you're at and what it took to get to become an orthopedic surgeon today?
Yeah, that's a great question. Yeah, I think like anything worth going after is worth putting. You mentioned the word earlier, persistence and hard work. So, I mean, getting to being a professional athlete and playing for the under-23 national team to then becoming an orthopedic surgeon, it's really very similar as far as putting your mind to something and working hard. There's some, people use the term luck, but I think luck is really just persistence and hard work, becoming opportunistic, putting yourself in the right place at the right time, and so I think that comes with just being the term Johnny on the spot. You're just ready, you work hard, and so I've it wasn't easy, but to retool after a career and get back into a different career, there's a big challenge, unknown, and a big leap of faith, and it certainly has been worth it.
Wow. Wow. That's amazing. I wanted to dive into that transition there, um, because that's probably relatable to, a lot of patients that you see on a day-to-day basis that they're going through this surgery and, they were living one lifestyle. After surgery, there's a transition phase there where they're not maybe able to carry out everything that they were doing previously until they get through the recovery part of that. So, you mentioned you had an injury. How did that go for you in your perspective? And how did that rebound look on your side of things? Were you able to quickly dive into your new career? Or if you don't mind, talk a little bit about that transition there.
Yeah, absolutely. I can kind of relive the day of injury. So I was drafted 15th overall by Dallas. They were Dallas Burn at the time. They since changed their name to FC Dallas. But in 2003, 2 days after I was with the U.S. national team, under 23 national team playing in Portugal, we were playing Russia, and I consistently would get the nod. And we were actually preparing for the 2004 Olympics qualifiers, and we were supposed to play Mexico the next month in Mexico City. To the winner goes to the Olympics. Tore my ACL, MCL, meniscus 2 days after one of the biggest days of my life, and so yeah, I can definitely relate to even though the disease process, the pathology I deal with is osteoarthritis or post-traumatic arthritis or other end-stage joint disease. And so, but still, once you have an operation, there's a recovery standpoint. And so I can relate, while it's different surgery, I can relate to the mindset that it takes. And so that recovery is, as in your business, is coming back from an ACL is not overnight. And depending on the patient, the surgeon, the activity expected to return to, it could be every bit of 6, sometimes 12 months or longer, based on the expectations. And so, where I was able to excel, and it was a bit beneficial because that was my job. So all day, every day, I worked with the trainers and physical therapists. But it was a huge commitment, and it was 6 months before I was even a morsel of what I was before I was getting back. And even still, I think, years later, you can tell, like taking a new car off the lot and you wreck it and you put it back together, and it just never quite runs the same. And so even though I was still top notch, you could tell there was probably a little bit of percentage gone. And so that injury really, it allowed me to, dig down deep and figure out what I was about and come back. And I was able to come back. I left on different terms, but it definitely changed my trajectory for sure for soccer. But I think I benefited in this career having that experience. And that's why I think the transition has been pretty good for me. But also on that note, it matters, obviously for what I had, my own mindset in recovery, but I had to lean on people like what you guys do and athletic trainers. So I had physical therapists and athletic trainers around me at all times, and also support. It was a very tough time. You go from the top of your game to the lowest part of your game, and patients deal with that too. My wife was a big part of that, helping me get back, not only in soccer, but then when we decided to transition to a different career, it was you have to have good support, the assistance part, but also the mind, body, soul, the spiritual part of it too.
Yeah, that's such important to recall on. The support system around going through one of those phases is super important, and we see it, oftentimes with the baby boomer generation is going through one of those major transition phase where a lot of them are now into retirement years or, approaching that or have been in that. And so at times we'll get their stories where at the end of their career, they're looking into what they want to do. And I want to travel, or I want to be active with my church, or, my grandkids, or that kind of thing. And so do you pull some deeper meaning for yourself as far as what you do to be able to help that generation that's looking for your service as far as getting a knee or hip replacement that'll maybe allow them to do the things they've been looking forward to doing?
Yeah, what a good question. And it's more and more hip and knee replacements are being done because people are living longer and being more active for longer. The days of, you get old, you retire and just sit in the chair are done. I mean, I think those, being active, staying up with the grandkids, and so that, yes, I get a lot of satisfaction in helping people return, not only return to the activity they want, but in a lot of ways improve, because they had usually were dealing with a bad joint for much longer than they knew. It would limit them, or much longer than they would admit. And so then you sort of go backwards after a surgery, just by surgery, and then retool and come forward with something much better. Sure, it's not the joint that God gave you, but neither was the one that we had just replaced. And so it's sort of an addition by subtraction, and there's a lot of satisfaction in that. And I have patients come in and, dead set on avoiding the operation, and that's fine. I mean, in fact, my goal is, I was taught by mentors much smarter than me. You give everyone the option other than surgery, let them decide on it. And so that's always my goal. I talk people out of surgery till they'll talk me into it. My role in that is just to tell them how, the severity of it, and if they're a candidate for surgery in their future. And so once I've sort of said that piece, I'm there with them along the way, whether it's injections or other things. But yeah, life is way too short to be, hindered by something that we can take care of.
That's such a awesome statement there. And I know that you could probably say that you relate a lot to those baby boomers, cut of the same cloth, with that persistence and that grit per se. You mentioned in your backstory there, and that was the foundation to not only you, but you mentioned your parents had a lot of their hands on blue collar style work growing up. And so I'm sure you can relate to, again, the clients that you see on that manner. And then also you mentioned coaching them. So that's another thing that you could tie into your background. It's probably more of, I'm not going to tell you you need this or to get this, but we're going to work through it. I'm going to kind of coach you through your options and let's figure it out together, kind of thing. So that's awesome to hear there.
Yeah, you really pick up, and I know you see exactly the same. Like parenting, I know you have children, and coaching is a good example. Teaching, you have, there's not everybody fits the same mold, so you kind of find the best way to approach each patient. A lot of times you may not know it right away, but it evolves as you get to know people. But yeah, I have some patients come in, y'all see that you have to give them very little direction, and that doesn't make them better. That's just their style, and they've just run with it. And then some patients really need a lot of coaxing. My wife and I joke, she'd had a shoulder problem a few years ago, and I gave her a bunch of stuff she could work on, and she's like, "Well, don't think I'm gonna do it by myself." So we had her set up to have some assistance with some therapists, and she got through it quite well. But she knew that about herself. It was going to be harder for her to do it on her own. And so you kind of you tailor treatment to each patient, individualize it, as you were alluding to. You just kind of figure out what's works best for people and support them in the best way you can.
Great points there. Yep, that's definitely something that, as you mentioned, we see in our clinic, and we try and work out as well with our clients when we're going through that process. I wanted to dive into what kind of conditions or cases do you most frequently see? We talked about knee and hip. And then also I wanted to mention that you're mostly doing anterior, or only doing anterior hip approaches. Is that correct?
Correct. I'm a exclusively anterior hip replacement guy. I do approximately about 1,000 hip and knee replacements a year. Of the hips, it's all anterior. Now, on occasion, when I have to do any revisions or redos of hips that have been sent to me from wherever with problem, I will on about 50-50 if I'm able to do it through the anterior approach or if I need to go through the side, based on the complexity of that situation. But yeah, for a first time hip replacement, 100% anterior approach. The nice thing about that is it's muscle sparing. And so, and it's, a lot of people perseverate on the length of the incision. While sure that's important from the aesthetics, but the nice thing about the anterior approach, it is really pretty short incision because of the special table I'm able to do the operation on. It allows the leg to be dropped and expose the femur of the thigh bone through the incision, and it just allows access to a much smaller incision. Incision is not as important, but the fact that what gives the anterior approach, the reason it's more modern, I think the research is pushing towards it, is that it's, again, muscle sparing, so there's no taking down of a muscle, rather than just going between two muscles. The other approaches are still fantastic. The lateral and the posterior approaches, the surgeons that do that, especially in this town, do a very good job. It's just that anterior is definitely, a lot of stuff is pushing towards that.
Awesome. So just to be clear on that, just for layman's terms, when you mention anterior approach, you're talking about coming in from the front of the body, and
That's
then
correct.
lateral would be coming from the side, and then a posterior would be coming from, the back side
That's correct.
of the hip. Yeah. So the benefits of coming from the front, you mentioned there was a lot of research showing that that's really beneficial as far as recovery and that kind of thing. Can you talk about, what that may look like with an anterior approach?
Yeah, you're right. The research is really starting to push towards the anterior approach, and it's showing that because it's muscle sparing, it usually helps with pain after surgery. Surgery still hurts, so I tell people, yes, I mean, but the types of pain might be a little bit different. How long that pain lasts might be different. The fact that it's helps with pain, helps with muscle sparing. Your strength is usually maintained after surgery.
So real quick, so when you say muscle sparing, you're mentioning, that we're actually not cutting through muscle. Is that correct?
Correct. That's exactly right. So instead of having to cut into a muscle, which is common for the other approaches, and again, it's not a knock on them, it's just the advantage of the anterior approach, is the front of the hip approach, is that there's a plane between two muscles on the front of the hip, and so you never have to tug on the muscles, but you don't have to cut them, which can help with strength after surgery, help with pain after surgery. It affords the research says a little bit quicker recovery. What we do know, it might be quicker in the beginning, but by 3 months, by a year, they all equal out. But I think it just allows people out of the gates a little bit quicker. It's a good approach for any age, but I think the most beneficial people, probably the younger, more healthy, active people. But it helps everybody.
Wow, that's awesome to hear. That there continues to be advancements in medicine, and not that long ago, hip or knee surgeries may have been in the hospital for much longer periods. And so this is just one of those kind of evolutions of research. If you don't actually have to cut through the muscle, that we can get the patient a little bit more active, a little sooner. They can, maintain some of their strength, that kind of thing.
Well, the other thing I can add is also the anterior approach. Statistically, it gives a slight lower dislocation rate where the ball comes out of the socket. And so I think most anterior front of the hip replacement guys have basically no restrictions after surgery. We're not as worried about positions of the hip. And I know that's not only helpful for patients, but I know for your field, I know therapists really love knowing that they can not be aggressive, but they're not limited on helping the patient. Of course, any artificial joint can come out in the right circumstances, but the anterior hip usually has a lot less restrictions after surgery, which is always quite nice.
Always good to have, a lot more confidence in the patient's ability to move, knowing that, there's a lot less risk with that dislocation. So that's awesome to hear. Is there any common misconceptions or misunderstandings about your role or specialty that you hear in the clinic or maybe in the community that you'd like to kind of debunk at this time?
That's a good, tough question. I guess first and foremost, and this is defend all guys who do any replacement of a joint, especially hip and knee more than anything, is that and I understand that, but once you tell a patient that their joint is, whether it's bone on bone or, you know, the terms bone on bone or osteoarthritis or degenerative joint disease, and if it's severe and they're a candidate for knee replacement, a lot of times when we're all human, the less they hear that you have to have that, you know. And I spend a lot of time telling people, no one has to. This is not a broken hip. The time at which you have your joint replaced is up to you. You know, a lot of people will allow themselves to become less and less active, more and more, be in a chair longer and do less of the things they like just because they're adamantly opposed to surgery. And that's okay. I tell those patients, I'm along for the ride with those patients too. We're talking injections, whether it's hyaluronic acid or if it's the steroid injections or therapy utilizing you guys. There's a lot of success that can show that physical therapy can help prolong someone having surgery, but also that, you know, you guys hands are tied as well. You know, once the joint's broken down, we're limited. And so, you know, that's one thing. So I like to, you know, make sure I try to explain to patients in clinic that I'm not saying you have to have it. That's the only way we can definitively treat that. And so as far as when, that'll be their decision. Other things that you hear, you'll have people talk about minimally invasive knee replacements. Those things are a misnomer. Anytime you have a joint replaced, it is not minimally invasive. It's you're opening a joint up, you're putting metal and plastic. So when you hear those terms, those are billboard material. Someone's just trying to use some basically fake advertisement to get business. And I don't believe in doing that. I cut it straight. For instance, the anterior approach, that front of the hip replacement, some people will utilize the term minimally invasive, and I tell people it is not minimally invasive. It's still a hip replacement. And I do that surgery, but I don't want people to think, I don't want them to be misunderstood what that is. So, you know, muscle sparing or different, a better term, or, you know, not cutting the muscle. Those are a couple of things. Other things you hear, you know, you'll hear about whether that's stem cells or PRP, where you take your own blood, these things to help
Right.
avoid knee replacement or hip replacement. And those things have a place in medicine, but unfortunately, once the cat's out of the bag, so to speak, once the joint's breaking down, those things can only help just potentially buy some time. There's no return to normal. There's no delay of normal once you're in that arena. And so there's a role for them. I'm not saying they're not useful, but I think that when patients come to me and they've spent a whole bunch of money with different companies putting a bunch of stuff in their joint and complaining to me that they lost all this money and I think, again, false advertisement. There's people out there saying things that aren't true, and I think those things need to be wrangled a bit. They have a role. They're just probably not in a way that they're being advertised. And so,
Yeah, those are really great points there, Dr. Thompson. And I think you mentioned just always be aware this is an elective surgery. And so let's elect into it. Let's educate yourself around it and figure out when the right time for you to do the operation is. And so I know there's a lot of people that maybe need this surgery, but they're not in a point of life where they can really afford to step away from what they're doing for the window that you need to rehab or recover. So I know that's a lot of the coaching side of things that you're discussing there. And so that's got to be a great thing to hear from the community, that there's a doctor who's doing these surgeries that's willing to have those conversations and kind of guide you through that process there.
that's a really good point. I tell patients, you know, for instance, a knee replacement, you know, it's a very painful recovery, and not for all, but for a lot. And so you have to be ready to put that time in, because most of the time, I'm not 100% of the time, but most of the time, patients who aren't satisfied with their joint replacement probably didn't quite attack it or weren't quite ready. And so I tell patients, you really need to be ready, because it's not a sprint, it's a marathon, and you have to be ready for the grind. And so if you're not, whether it's mentally, physically, spiritually, or, you know, it can affect you for a long time. And replacing a joint that's just one part. Once it's replaced, there's so many other things around a joint that need to be rehabbed, and undergo therapy. And so sedentary, the number one reason for joint pain, whether it's replaced or not, is being sedentary, being inactive. And so replacing a joint, replace a joint, but there's still a lot more work to do.
Yeah, I mean, the whole point of, trying to uh, get through the process of the rehab, like you mentioned, is trying to make sure that you're leveling up per se your active lifestyle. And so, are you doing that? Do you have plans to do that? And what does that look like post surgery? So, yeah, those are all great talking points to kind of really dive deep and consider when you're thinking about getting those knee or hip replacements for sure. To follow up with that, what's one simple step that someone can take today who's maybe thinking about, is this right for me or not, that they could prioritize their health even before they call your office? Anything on that realm of things?
Yeah, that's a really good question. I think that I'll have patients come in who have some pretty bad joints, but they stay active, and they of course, and active has different levels. And I'm not saying people still have to be, I don't know, run marathons or bicycling around town, or but just keeping your body moving, doing some resistance training, stuff like that. uh, Keeping your core muscles, whether it's your quad, your core, your low back, these are very important muscles and our stability. And so, well, people who are maintaining that, and obviously the things that we all know, a good diet, keeping our weight somewhat under control, these things are protective. And so, even with bad joints, patients with pretty bad joints, but they're able to maintain an active lifestyle. And so that becomes protective. And I think that's why some of those patients end up prolonging the need for a replaced joint, because of their activity level and being a little more proactive in their health. And I know it's easier said than done. I completely understand that, but this is just from my side of things, what I'm able to observe.
Yeah, always easier said than done. But yeah, for sure, staying as active as you can is definitely something that we see as common ground. We're always trying to make sure that patients are maintaining whatever active lifestyle they wish to, and understanding that, just because you have degenerative changes in your joints doesn't mean that you have to succumb to an inactive lifestyle.
On that is, and I guess where a lot of people will decide to be more aggressive with their treatment is when they aren't able to maintain that active lifestyle.
Yeah.
That's usually a good line in the sand, where we'll see, once you start seeing the inactivity because of a joint. And I have a lot of people who maybe have not, maybe pain's not their main complaint, but a joint that just doesn't support them, for different reasons. And so they maybe pain's not their number one complaint, but it's other things. And so they might be more aggressive too.
We may see someone that goes through that rehab process, their knees moving well, their hips moving well, they're fully rehabbed from that perspective, but they have something else that's limiting them now, that maybe was kind of under the shadows previously because their knee or hip was, more forefront in their mind. And so, is that something that you've seen with your patients as well?
Yeah, absolutely. It's real common, especially in the hip, where there's my partners who manage the spine, doctors Michelle Borkowski and Mickemeyer. We share a lot of patients, especially with the hip and the back, where someone will go to them with quote unquote back pain. They'll find that it's actually probably their hip, or vice versa. Come to me for a hip, or Dr. Clemish for a hip, and find out, well, we think it's the back. Or you do a hip replacement on a patient, and all the pain they had in their hip and their groin is gone, but now they're seeing some of these radiating leg pains and paresthesias, and maybe a distractor was the hip, and then you take care of the hip and it alters the mechanics that now put some stress to the back. And so, the whole song of, that had leg bones connected to the thigh bone, that there's a lot of truth to that. So we really just try to maximize people the most with doing the least, until we have to intervene.
So we've covered a lot today. Is there anything else that you'd like to touch on that helps people understand, any place you want to dive deeper about what we've talked about today?
No, I mean, you've asked a lot of good questions, great questions, and we share a lot of patience, and it is a journey, and I really try to do the best I can, and like all of us, we're human. I try to do the best I can to help prepare people and coach people and counsel people through all this, and you know. Sometimes most of the times people do fantastic, and sometimes it hits people a little harder than they were expecting, and I try to help them through it. And the vast majority of time we are able to get people through these big surgeries, and with the help of your field, and especially your facilities. You'll do a great job of taking care of our patients, and so we see that with good teamwork, we get people through it.
Thank you so much for that. That's amazing to hear. We talked about research as far as the anterior approach. Anything else from surgical perspective on that side of things that you want to cover today?
Yeah, the anterior approach is very modern. Outpatient joint replacement is very modern. Robotics, I do robotic knee replacement. That's very modern. Again, a misnomer is that robotics changes outcomes. What it does is changes outliers, but the studies will show that the patient's outcome doesn't change whether robotics are used, but it does change the outliers from a surgeon standpoint. But another new tech, not new, another good technology that I'm utilizing, hopefully to help patients and their confidence in the operation and the surgeon. But not required, but it's certainly a cool technology that really has changed the game lately.
I see. So does robotics help speed up the process, or what made you move towards utilizing robotics with your total knee replacements?
A few years ago, I made that jump. I was always told by a mentor that don't be the first at the table or the last. And so the literature is really pushing towards not requiring, because the high volume joint replacement guys like uh, don't necessarily require that. I think what it has added though is more precision. It doesn't change it doesn't change the speed of the surgery. I think efficiency and high volume guys have a speed that not a rush, but just an efficiency through the operation, whether it's with robotics, with computer navigation, or with the old instrumentation. And so it's just a matter of having a high volume surgeon who knows issues right away when they're encountered and can manage them. That's probably the most critical thing. And I like the robot because it gives me a lot of information. And so not only before I'm putting the metal on, but also by the time I've decided upon the sizes, the positioning, the resections of the bone, how much is being cut off. And so that really, and it's not cutting, it's more shaving and resurfacing. And so that just gives me a lot of information that I like. I think in this day and age, the more information you can get, the more you can synthesize, especially as you see a lot of it, you can use it to help my satisfaction before I close the patient, and ultimately, hopefully, the patient's satisfaction after the operation.
I wanted to ask a few questions that I know my patient would kill me if I didn't ask. So if you don't mind, I'll just fire off a few common questions that I hear in the clinic. As far as the internet goes, there's a lot of things out there, a lot of resources, videos, that kind of thing. Do you recommend a patient watch a total knee replacement, total hip replacement before they go see you?
That's yeah, I guess coming off robotics, I like information. And so for me personally, I like know as much as I can before. Um, some people handle a lot of information well, some people don't. My wife, on the other hand, she doesn't like being overwhelmed by a whole bunch of information, and trusts the entities that are. So I'm different. I like a lot of information, and so I think the patient should feel that they're well informed. If that means they watch a video, fine. If that means they read some literature, I will say that sometimes those videos can be very for someone who doesn't see that kind of stuff, that it can be barbaric. But I mean it seriously. I'm a glorified carpenter, and so it's carpenter, wood is typical, and bone is very similar to wood when it comes down to it. And so if that's going to help people make a decision, I think that's good. If it's going to scare them off, and I don't know, I think they probably should, whatever makes them have the most informed decision was what I would recommend.
Great points. I think it goes back to what you mentioned, minimally invasive, probably not the best term to be used. As described, if you do decide to watch those videos, you'll understand how it's not really appropriate for, what's going on there. Another question here, clicking and popping. We hear a lot about clicking and popping. Patients may think, my knee clicks and pops all the time. Is that an indicator that I need to have surgery? Or even on the other side of the spectrum, is clicking and popping something that I should anticipate or expect post total knee replacement?
Great question. And obviously a common one I get in clinic. Clicking and popping before or after surgery, regardless of the knee, whether it's degenerative joint disease or a normal knee, a young knee, if it clicks or pops and it doesn't hurt, I think the vast majority of people, surgeons, doctors will tell you, don't worry about it. If it clicks and pops and it doesn't hurt, don't worry about it. If you want a peace of mind, we certainly can look at it, but my knees click and pop, things click and pop, doesn't hurt me, so I don't worry about it. After knee replacement, same strategy. If it clicks and pops, it doesn't bother you, don't worry about it. But after knee replacement, it's very common for the metal and plastic. There's a little play. You take a negative pressure joint and you put metal and plastic in there, and you can never seal it back up like it was before. No, it's sealed up, but you never get that suction effect back of the joint. And so there'll be a little bit of play between the metal and plastic. There's also a soft tissue layer inside the joint called synovium. It's nutrition to the joint, and it's there before surgery and it's there after surgery. And so kind of like moss floating in a lake or a creek or something, it finds its way. It's going to find its way. So some people will have that more than others. As a surgeon, it's hard to know how much you take out. You can't possibly take it all out because it'll devitalize the knee. So you take some of it out in the places that are important, and then the rest just figures itself out. But almost always, I tell people, you give it long enough, like smoothing out a rock where water keeps running over it, it'll eventually smooth itself out and won't notice it. So there's rare times where it can be problematic long term, and there's things we can do to help with that. But the hope is that people give it long enough that it smooths out, so to speak, and stops bothering them. But overall, clicking and popping before and after surgery is quite normal.
There you have it, clicking and popping, quite normal. So pay attention, but don't worry too much about it. If you need to ask for sure.
Yeah, that's right.
Anything else on your mind that you wanted to cover today?
Yeah, one more thing. It's just that strength after surgery, stamina, endurance is critical, and that's why leaning on you guys, and not just when you guys are very smart, therapists are very smart, and so outlining, getting my patients to really lean into you guys and rely on you guys is critical. And not just when they're with you. And I know you guys give great exercise, home exercise programs, and it's not, you work with them 3 times a week, but the other 4 days and the rest of their life is on a patient. And so I empower patients to use what you guys, all the great information you guys give them and direction, and do that at home too. And it not only helps you guys, but also helps them in long term, because I use probably a bad statement, but you guys work with them 3 days a week. I do the surgery 45 minutes an hour, and we're done, so to speak. And it's their joint for the rest of their life. And so it's real important that they commit to it, and success will come. I tell people, you challenge it, it will respond.
For sure. Everyone has, their own unique journey, as you mentioned several times throughout the talk today. And So use your resources. It's great, as you mentioned, working with a great team. We enjoy having you guys as a resource, and the patients love that as well. And so we do our best to try and tap into all their avenues and make sure they're set up for that long-term success, as you mentioned. So that's great to hear.
Yeah, it is. It's I love it. I love seeing patients do great, and it is a really cool thing. And not talking to you about strength and work these patients have to do. I'm not trying to sit here and sound paternalistic. I'm along with the journey. I'm not trying to come off that way. It is a tough surgery. We hip and knee replacements. It's a longer recovery, but it is possible, and we see phenomenal patients all the time.
Thank you so much, Dr. Thompson, from the bottom of my heart. We talked about so much today, everything from your early beginnings in soccer to your injury, to your transition to becoming an orthopedic surgeon, and why you chose the clients that you help today, with total knee and total hip replacements. Give back is a core value with Avila Physical Therapy, and there's no doubt we were able to accomplish that goal here today. So thank you. Thank you. For everyone following along, stay tuned to find out who will make the next guest appearance on the Coastal Bend Spotlight Series.